The following is my experience with a feeding tube insertion. I'm not a doctor, so get medical advice. Based upon my discussion with several pals, there are wide-ranging recommendations from Canadian ALS neurologists as to when a feeding tube should be inserted. For my research, a feeding tube should be considered if one of the following conditions are met. Number 1, breathing capacity is at 70% or below. Number 2, a BiPAP has been prescribed. Number 3, starting to or have been choking on foods or liquids. Number 4, short of breath on your back. Number 5, bulbar ALS. The advantages of early intervention are better toleration of surgery and possible complications. Radiology departments don't like dealing with patients who have compromised breathing, especially if it's only 50%, since it severely limits the medications, such as CNS depressants like Ativan, that they can use if something goes wrong during the surgery. Therefore, the better the breathing, the safer it is. Advanced PALS have an increased incidence of excess saliva, which may cause a risk of gagging when the patient is lying prone on the operating table. There is also the complication of air leaking out around the incision if a BiPAP is used, and if the PALS has to suspend BiPAP usage, this could be life-threatening if the PALS breathing is very poor. Another advantage is preventing avoidable weight loss and possible slowing of ALS. A feeding tube will prevent weight loss due to inability to eat or lack of appetite. The excess calories may even slow progression. See the study in the links below. Another advantage is early competency of feeding tube usage by PALS and caregivers. As with any skill, time is needed to feel comfortable using a feeding tube. If this skill must be learned under pressure, it adds unnecessary stress to an already very stressful situation. You may also avoid unnecessary hospital expenses. Emergency room visits due to impacted bowel can be minimized with proper fiber and hydration through a feeding tube. 911 calls due to choking can be avoided. Also, avoidance of emergency PEG placement. It may take several weeks or months before radiology departments have an available appointment. If there are complications with the surgery, this may be several weeks more to get the appointment. By this time, the ALS patient may be in dire need of surgery due to choking and/or weight loss. This is an extremely stressful situation for the family and the patient. Also, there is a better quality of life because the patient can eat for pleasure and not be force-feeding themselves to ensure that they can maintain their weight. For my pals, if he choked, it would be very difficult for the rest of the day because he would often continue to choke on the food. The disadvantages of early intervention are burden of feeding tube care. The tube must be flushed daily, and the feeding tube must be monitored and changed by the hospital occasionally. There is the burden of feeding tube expense. The adequate supplies for feeding tube maintenance must be purchased. Also, there is a restriction of patient activities, such as swimming. Getting your feeding tube early is always better than getting it too late. My pals was choking early on, and the doctor kept telling him to wait. It finally got to the point where my pals was unable to eat, so we had to urgently request the tube placement. Unfortunately, my pal's stomach was too high and the ribs too low, so radiology couldn't insert the tube where they normally do. This involved a week full of stress, while my pals was not eating very much, in an attempt to get a specialist to do it. The stress could have been avoided if we just got it early. Also, if you wait until your breathing is below 30%, it is dangerous and there's a chance you have to be intubated. After surgery, the three main issues are gas, nausea, and pain. For gas, we tried Gas X, but it didn't work. We found Atrantil was the best. It is an herbal supplement. You can also vent the tube. You basically hold the tube up, open the tube, and let the air equalize. We did this every hour in the beginning. Do not ever drain the liquid from the tube. This is your stomach acid, and if it is drained, it can offset the balance of acid in your stomach and possibly require a trip to the emergency room. For nausea, Zofran worked really well. It is a wafer that dissolves in your mouth. You will need a prescription for this. Chemotherapy patients often use it for nausea. You can try Gravol, but this didn't work for my pals. If you vomit after you get your surgery, it can be damaging to your wound, so ensure you have everything in hand to get the nausea under control immediately. For pain, they will probably tell you to use ibuprofen, which is Advil. Pain is not that bad for some people, but just be prepared in case it is. Tylenol 3 may be helpful, but you need a prescription. The doctors are extremely hesitant to give anything stronger than that. that is opiate based, such as hydromorphone, but some people I've talked to have needed it. The steps before surgery. Number 1. Stop all blood thinners a week before. This includes Edaravone infusions because the flush is heparin, which stops blood clotting. This also includes herbal supplements which thin the blood. Consult your doctor about prescription medications which may thin your blood. Number 2, see your doctor and get a prescription for nausea and pain control. Number 3, get anti-gas and possibly anti-nausea from the drugstore. Number 4, prepare to have someone care for you 24 hours a day for the first few days in case you need it. Number 5, if available, have your health network set up a nurse's home visit for the first few days to ensure everything is okay. Surgery. If you get the surgery done at radiology, they put a tube down your throat and pump your stomach full of air. They then use radiology to guide them where to place the tube. The procedure is quick. It takes around 15 minutes. However, the doctors would not give my pals any Ativan to help him relax and only a very mild painkiller. Depending on the hospital, and if your breathing rate is higher, they may give you more drugs to help you relax. It was very uncomfortable for my pals, but again, it was generally quite quick. Maybe take relaxation music to help you out. They also do spray a numbing agent on the back of your throat, which my pals didn't like because he felt he couldn't breathe that well with it. The position of the tube insertion varies. My pals had to get it in lower on his abdomen because it was the only safe place. Here is another location of insertion. My pals was told not to eat or drink anything for 24 hours after surgery. We had a nurse give him IV saline at home through his portacath. This helped immensely to prevent dehydration. We also used an eyedropper to drop ginger ale and water in his mouth since he was choking when he drank, so he couldn't sip on water or ginger ale. Some people stay in the hospital for 1 or 2 nights after the surgery. My pals was also incredibly itchy for 2 weeks after the surgery, and later we found out that he is allergic to an antiseptic used during surgery called chlorhexidine. However, an allergy to this is rare. After the surgery, the wound oozed for several weeks, so the bandage was changed at least every other day. A saline syringe was used to rinse the area, then the new bandage was slipped under the part next to the stomach. Avoid getting soap around the wound when you shower. Watch for a red rash or smelling, oozing, or pain. We taped the tube down around the lower part of his breastbone. We also cut a hole in his shirt on the left side and pulled out the tube so it hung easily when he was eating. I bought these waist belts that were supposed to hold the tube in place, but my pals moved too much and they moved around a lot. Tape the tube near the chest area, not the stomach. The skin tends to fold around the stomach more, and leaving tape on there for any period of time causes the skin to get wrinkled and sore. Also, my pals developed a blister underneath where the tube was taped because it was taped on the stomach where he sweats more and there is more movement and rubbing. Use alcohol wipes to wipe off the tube occasionally and also get rid of the adhesive on the chest once you remove the tape when you're changing it. If you wish, you can request a low-profile Mickey after several weeks. However, there is an extra cost since you must pay for replacement every 6 months, and the Mickey requires an extension tube when feeding. We didn't get it replaced because my pals is hooked up for 3/4 of the day to the feeding pump anyway. Overall, my pals is very glad to have gotten the feeding tube. I hope this helps with you, and good luck with your surgery if you're going to be having one soon.